everybody. I'll just have to click got it so that we don't bump off, but Nora's recording. Welcome to all of our summer graduates, to the summer thesis presentations, and to family members and supporters and peers in the cohort. So nice to see everybody here in one place. I hope that all of you have had restful summers. I do know that the thesis presenters have been working very, very hard through the summer to be able to deliver these talks today. Just as a bit of background for those of you that don't know, the thesis presentations are, one of many components of the MPH program degree requirements. And it's kind of, I guess, the crown jewel in that, you'll get to hear about, these long-lasting projects that folks have been working on through many challenges of COVID and having to go remote. So thanks to everybody for their support and their flexibility, of our candidates who are about to graduate. And we'll go ahead and get started. Just to give you a preview of what we're about to hear, the presenters have 10 minutes to present, and then we open up the floor for 5 minutes for question and answer, and anybody can ask questions, family members, peers, faculty. So thanks to everybody who is able to join us, and also special thanks to all of the mentors and faculty who have helped to bring about this work and have supported our students throughout the last 2 or more years in some cases. So thanks and nice to see you. Nora, am I forgetting anything that I should mention?
The only thing I'd like to add is please add your questions to the chat box, and I will get to it as soon as the presenter is done presenting. So I'll address it then. Thank you.
Yeah, thanks, Nora. I forgot about that. I think the best way to get questions is definitely through the chat. So, okay, so with that, Megan is going to start us off. The floor is yours.
Wonderful. Thank you. I'm going to try and make sure that my screen share works appropriately. Let's see. Can you see my slides?
We can see your slides and your notes.
Okay, so my apologies. I was working to get this sorted out yesterday. So let's see, maybe I'll just share. Hopefully this works. Can you see just the slides now?
No, it's the same thing as before.
Megan, if you use go back into that portion, there's a button at the top that allows you to switch views from swap displays. Perfect.
Okay, great.
Yeah, that worked. Please write what you did in the chat, or your advice in the chat, Katie, because many other people were, and I actually didn't catch what you had to do. So if you could disseminate the information, it would be helpful to us all.
Thank you.
Go ahead, Megan.
Awesome. Well, good morning, everyone. Thank you so much for joining. I'm really excited to share my qualitative research with you about perceptions of adolescent pregnancy in Loreto, Peru. My name is Megan Bernachez. I use she, her pronouns, and I had the honor of working with Nancy Puttkammer as my thesis chair and Magali Blas, my thesis committee member throughout this process. I'd like to start by sharing some of my positionality that I know distinctly informed my research perspective. I'm a cis heterosexual female. I'm not yet a mother. I grew up in America and I was not able to travel to Peru due to the COVID-19 pandemic. I also speak Spanish as a second language, which I'm very aware of. I also had access to sexual and reproductive health services while growing up. And I was educated in the US. I'm currently a graduate student at the University of Washington, pursuing my master's in public health as well as social work. I also want to take a moment to name that because of the focus on birth, you will hear terms like women and girls used throughout this presentation as the assumed birthing population. This reflects the scope of the research. However, it does not reflect the scope of inclusive birth experiences, and it dismisses trans and non-binary birthing people. I encourage research around pregnancy moving forward to aim for a more inclusive perspective. A little bit about the background. First, it's important to consider why adolescent pregnancy is a public health concern. The period of adolescence is a risky time to have a child biologically because it leads to risks for both the mother and the child, especially before the age of 15. Psychologically speaking, there are also concerns that adolescents without a fully formed frontal cortex are less able to cope with the challenges of parenting and have less resources to provide for their children. In the long run, adolescent pregnancy is associated with lower educational attainment and lower wage earnings, thereby perpetuating the cycle of poverty. Specifically for my research, I had the honor of working with Mamas del Rio, which was founded by Magali Blas in association with Catiano Herrera Peruvian University. Mamas del Rio has a mission to work in rural communities of Peru to reduce maternal and neonatal mortality through the empowerment of community health workers. However, they don't currently have any programs that support the unique needs of adolescents they work with in this region, Loreto, which has particularly high rates. So let's take a closer look at Loreto. Loreto is located, my apologies. Loreto is located in the Amazonian region of Peru and is a sparsely populated region where many communities live spread out along the rivers. Boats are a primary means of transportation, and wide river floodplains change access to the city throughout the year. The economic opportunities are largely fishing and agrarian based, unless you travel to urban centers like Iquitos. Throughout this region, there are known to be about 58 distinct indigenous groups, but specifically for this study, the Kokama people and traditions are the most prevalent. And notably, Loreto has a particularly high rate of adolescent pregnancy. While the average age of first birth in all of Peru is 22 years old, for Loreto, that age is 16.6 years old. Another metric to consider is that 25% of all female adolescents residing in the region are or have been pregnant, which is nearly double the national average. Additionally, among all women, there are low reported rates of contraceptive use, and even fewer of those users engage in modern contraceptive use. A side project with the original research team included a photo voice workshop, and while the data wasn't sufficient to analyze for my purposes, I wanted to share some of the photos without any easy to identify faces to orient us to what this community looks like and to give a better sense of daily activities for adolescents, including work, study, and play. And these are the names of the communities that participated in the research. Some of the aims and methods of this study were really seeking to describe what the developmental period of adolescence looks like in Loreto, and in turn, to more deeply understand what are the perceptions of adolescent pregnancy and sexual and reproductive health held by community members. This descriptive study will be used to think about where Mamas del Rio can potentially tailor programming to meet identified strengths and needs of the community to more wholly support adolescents, while also considering how this research can inform future studies and possible advocacy positions. The data set I utilized was comprised of a total of 20 in-depth interview transcripts in the Spanish language. On the right here, you can see a pie chart breaking down the participants by respondent type. This data set was initially collected by 2 Peruvian and 2 American researchers in 2016 and 17. They used purposive and snowball sampling techniques until theoretical saturation was reached. As this was an additional project for the team, they didn't have time to complete their analysis, which is where I come in. After my initial round of inductive coding using the Deduce software, I was able to compare some of my codes to those of the original research team. I'd like to now share some of my results and the precipitating discussion points that came across from these interviews. First, I had organized my codes according to an ecological model, which stems from my social work background. And these are the 3 themes that seem to be the most salient among all interviewees, as well as the strongest concepts to point towards new ways of considering what adolescent pregnancy means and looks like to this community. The arrows in turn indicate the ways in which these 3 themes interact with and influence one another and are important to consider while delving more into each theme. So initially, we're going to talk about the Agency of Adolescence as a key theme. Overall, there seemed to be consensus that around age 13, young people have some degree of autonomy. Perhaps they're studying, planning to move to a city for work, or dating in secret. In all instances, they're testing boundaries and considering their options for the future, either educational or employment. Regarding education, the government scholarship program, Beca 18, provided opportunities for some scholars to pursue university education, but that was not seen as common or accessible for most participants. In terms of economic pursuits, it appeared that there are limited options outside of fishing and farming within the communities. Therefore, there's a pull to urban centers with a simultaneous tension to stay close to family. Overall, interviewees did not point to a gender difference in work options, but that may be because gender roles are so entrenched that women working in the home and men as farmers or fishers was implicit. To highlight this theme, I chose this quote because it reflects the pressure on youth to change their future in spite of these limited economic and educational options. For me, it would be ideal to finish your secondary school, finish your studies, bring forth a goal, achieve this goal. And then once you have your career, you can sustain with that, with your career, with what you earn. You have to maintain, sustain your home and what is missing and not missing. So shared by a 19-year-old adolescent male. Continuing on, we can look at the role of parents, which came through in all interviews. This may be in part because parents make up the majority of respondents, but further, it's because they serve as leaders in their household, as parts of parent associations in schools, as community healthcare workers, and as setters of community standards. Their perspectives and emotions around adolescence are indicative of the options available. We can explore the extent to which parents feel responsible and are held accountable for times when their children become pregnant. Many parents reflected a sense of shame in not protecting their kids or a deep fear that their daughters would become pregnant. Notably, it appeared that in the aftermath of the birth of a baby to an adolescent, the adolescent mother's family is most often the one caring for the new child. This pattern is reinforced because there's limited legal frameworks to hold the father accountable, especially when he's older or from another community. Here we have a quote from one father who feels it's his responsibility to share sexual reproductive health knowledge with his kids. We see that he recognizes the importance of gifting adolescents with knowledge, while at the same time, he notes that this isn't possible for many parents in his community. He says, well, it's on the parents to talk daily with our kids, daily, because if we as parents don't speak with our kids, they do what they do, commit certain acts, and sometimes become pregnant. And when they're already pregnant, they will quickly realize. But many parents here in this community still don't speak to their children. So considering why that might be, I'm going to fuse together the role of parents and our third theme, access to youth-friendly information and services. When we consider these two themes together, we see that in addition to the emotion of parenting teenage children, there's also this fear that the parents themselves don't have sufficient knowledge about sexual reproductive health knowledge to share and pass on to their children. It was only recently that the Peruvian healthcare system had invested significantly in family planning efforts, and given the hard-to-reach nature of Loreto, there's reason to believe that this generation is one of the first to have options of modern contraception. This is compounded by different experiences of information dissemination, which is dependent on the healthcare workers in the region. This mother reflects on how she learned about the dates or rhythm family planning method from her mother growing up. We learned through our mother before when she taught us. Formerly, there was not this method of care, pills and injectables. They took care of themselves like that, nothing more than talking between two couples, that they're in danger, how many days when we cannot have relationships. So to delve more specifically into access to youth-friendly information and resources, overarchingly, there was no shared understanding of how sexual reproductive health services in the community are delivered, or a consistent sense that there was sexual health in schools. And as this healthcare worker reflects, it's of the utmost importance to establish a more robust network of care in the region for youth to utilize. Because they start their sexual relations at a young age, 14, 15 years old, and they do not plan, they do not know what family planning is, how to protect themselves from pregnancy. Many adolescents do not know that they have to take care of themselves. I'd also like to point to some of the family planning methods that were most common that came through in the data. These are organized in order of frequency of use. So we still see that the not modern contraceptive methods, such as the date method and plant-based medicine, are most common. And then more barrier or pharmacological interventions are less common. And some important considerations are the role that parents' emotions may play in contraceptive use, and at times the influence of Christian religious practices, though that wasn't as frequent, and what inconsistent access to health posts might mean for interventions that require visiting a medical professional, such as injectables or the pill. Finally, I'd like to conclude by sharing some barriers that were identified in the data. Adolescents, for the most part, talked about feelings of embarrassment or shame in discussing sexual health and their challenges in accessing services independently. Parents talked about the secretive nature of adolescent relationships, feelings of powerlessness to protect, control, or inform their children, and the cost and distance to get to health posts. And community healthcare workers and medical health professionals talked most about inconsistencies in the rural healthcare system and the challenges for an already overburdened workforce trying to innovate to address these gaps. So next steps to consider for Mama Cell Rio are to utilize community healthcare workers. My conversation with Magali sort of immediately brought this idea to the forefront. There was some excitement around the prospect that community healthcare workers, by traveling from community to community, could provide information and potentially family planning methods to more adolescents. And beyond that, we can start to think about educational supports for parents and implementing sexual reproductive health in schools. All the while, it will be critical to involve work with both genders, ensuring a deeper balance of responsibility and thereby advancing aims of gender equity. Thank you so much, especially to my thesis committee, Nancy and Magali. Raquel and Neha both helped. They're part of the initial research team, the Mama Cell Rio community and those who participated in the study. And of course, the DGH community, my parents, friends, and partner have all been huge supports. So thank you.
Thank you, Megan. Nice work. While people are, oh, okay, we already have a question in the chat. So I have a question, but I'll save it until later. So the Nora, are you going to mention the questions, or would you like me to read them off?
I can read them off, and yeah, I can read them off.
Okay,
So,
go ahead.
Question comes from Farah, who says, "Great job, Megan." Oops, I lost it. What did you mean by education in schools being inconsistent?
Yeah, that's a great question, Farah. Thank you. It was very clear to me. There were many mentions of, oh yeah, you know, my child learned about sex ed in schools from their teachers. However, there didn't seem to be a shared understanding or consensus around what that consisted of, and it varied greatly from community to community. There's also one interview in particular that's very endearing to me of a 12-year-old adolescent where almost the whole thing is sort of pauses. There's clearly this sort of anxiety and discomfort around talking about sexual health. And so I think that a more intentional, accessible way of providing that education for youth in schools could be an interesting moment, although there might be some hesitancy around the Peruvian government's more traditional or conservative ways in implementing that. But because of the sort of informal nature where there is some sexual health education occurring in schools, there's an opportunity to sort of continue to work within that model that I'm hopeful about. Thank you for your question.
Perfect. And we have a question from a student who says, "Lovely presentation. Did you find any concerns raised when referring contraception as family planning and how it influenced youth perception?"
Do you think you could clarify that question? I'm curious, are you delineating a difference between contraceptive and family planning?
Nicholas, would you be able to explain that a little bit further for Megan?
Yes, thank you. A lovely presentation, Megan. I was just wondering, when talking to youth about contraception and referring to it as family planning, the times when the responses it may be different, when they could consider themselves not in a position to be planning their family, or that is not what their current situation is, and whether that influences how they perceive what is being presented to them.
Yeah, that's a fantastic question. Thank you for that. I think especially because this research was in my second language, I was really thoughtful about language and was super aware of even the extent to which Spanish is spoken in this region, and sort of euphemisms, like this term euphemisms came up in my code. Sort of walking in the street was how but many people seem to refer to adolescents dating in secret, like you see them walking together. There's an implication there that means that youth are coupled up in some way. Unfortunately, as maybe in the method section you saw, there were very few adolescent interviews. And I don't know that the language translated to be family planning. It was more so like, what methods are you familiar with to protect yourself? And there was more so a difference between sort of like pharmacological interventions, the pill or injectables, versus maybe condoms, and then versus vegetables or different sort of like plant-based medicine. So I wouldn't say that there was necessarily something that came through about adolescents' reaction to terminology, but there was definitely more data around types of intervention and sort of like language around how we think about that as a full group versus separating between method types to ensure safety of adolescents, if that makes sense.
Okay, thanks, Megan. How are we doing on time, Nora?
We are at time. Megan, there's a question from Steve in the chat box. If you can please just respond by typing it in there, that would be great.
Awesome.
Thank you.
Thank you so much.
Thanks, Megan, and thanks, Nora. Next we have Anupa Gaywali, but before I introduce you and launch you and give you the stage, I have to admit that I'm still drinking my morning coffee and I didn't introduce myself even to the audience here. So my name is Deepa Rao. I'm director of the MPH program now, recently inherited from Steve Gloyd, who's the associate director and here on the call. And I'm so pleased to be here and to see our graduates off and to hear about their important work. So thanks all again for coming, and Anupa, the stage is yours.
All right, is everyone able to see my slides?
Yes, and we can hear you.
Awesome, okay. All right, hi everyone. Thanks for joining this morning. My name is Anupa, I use she, her pronouns, and I'll be presenting my master's thesis, Uptake, Acceptability, Utility, and Preliminary Mental Wellness Impact of a Social Media Support Group for Perinatal Youth. My thesis chair is Dr. Keshet Ronan, and Dr. Deepa Rao is on my thesis committee. All right, so a quick note on my positionality as a researcher before launching into the presentation. As a woman of color, someone who did not experience adolescent parenthood, and coming from a middle-class background, it's important to acknowledge that I do not share many identities with the study participants that you'll hear about today, which can always leave room for power dynamics and bias. Also important to emphasize that young parents are the experts of their own lived experiences, and in this research, I have and will do my best to honor their shared expertise. Also, a quick note on language that in this presentation, we'll use the term birthing people as our primary term to center that there are many birthing people who do not identify as women, although the term mothers will be used specifically to refer to a previously branded program that has mothers in the title. Okay, so the perinatal period is a time of significant changes to the emotional, social, and physical status of a birthing individual. 13% of birthing people are affected by perinatal depression, which includes any clinically significant depressive symptoms during pregnancy or up to 1 year postpartum. Parenting people of color experience a higher risk of postpartum depression at approximately 38%. And adolescents and young adults under the age of 25 are at higher risk of perinatal depression than older age groups. And we see that existing societal and structural barriers are compounded for adolescents and young adults, especially due to limited autonomy and isolating factors such as lack of transportation. However, mobile technology can be used to build social support and overcome logistical barriers to in-person care. Technology-based interventions that are delivered through smartphone apps or the internet have been shown to be feasible and improve perinatal mental health. So one example of a program is the Mothers and Babies program, which is an in-person group cognitive behavioral therapy program, CBT, which has been tested in multiple contexts, and their materials are publicly available. You can see an example of their curriculum framework on the slide, and their program has been shown to prevent depression symptoms. And that brings us to Imagine, My thesis uses secondary data from the Interactive Maternal Group for Information and Emotional Support pilot study, also known as IMAGINE, which sought to adapt an existing CBT-based program, Mothers and Babies, which is developed for low-income racial minority birthing people in the United States. This is a small feasibility and acceptability pilot study for which I also had the amazing opportunity to participate in data collection and intervention development. The adaptation itself was specifically for delivery in the context of a social media group tailored for a youth audience. So in terms of the program itself, IMAGINE was delivered to groups of up to 10 via the online mobile messaging platform Slack. A trained social worker facilitated the group, sent graphical, video, and text messages to the participants 3 to 4 times per week. There's an example of one of our graphics on the right. The content was designed to promote discussion and personal reflection. So participants could get a text and then react to it with an emoji, chat back and forth, comment, ask questions, things like that. It lasted for 8 to 10 weeks, was primarily asynchronous for access through a smartphone. So they could pick it up, they could pick up the phone whenever they had a minute to spare and check their messages and still participate with an optional weekly synchronous Zoom session. Our recruitment was from February to December 2020, which was during the height of the initial pandemic response in Washington. So all of our recruitment was done through social media and virtual networks, as seen in this Instagram ad to the right. Eligibility criteria included pregnant or 6 weeks postpartum, between the ages of 16 to 24, having access to a smartphone, language literacy, and low depressive symptoms. So my first thesis aim is to describe the uptake, acceptability, and utility of the IMAGINE intervention. And the second is to obtain preliminary data on the association of the IMAGINE intervention with participants' mental wellness, including depressive symptoms, social support, and perceived stress.
5 minutes.
Thank you. And to help us get a sense of the timeline for the IMAGINE study and data collection, we've outlined our steps here. So from referral and recruitment to screening, which is where we collected the baseline depressive symptoms using the patient health questionnaire, PHQ-9 data, and move forward with eligible participants. And then on enrollment, we collected intervention on participant perceived stress and social support using the PSS-4 and SSB scales. The intervention was run, and then afterwards, during the follow-up questionnaires, we again collected PHQ-9, PSS-4, and SSB data. We also assessed acceptability using the Acceptability of Intervention measure. So to better understand the uptake, once we got to those 9 participants, we can see that of the 68 who contacted this, oh, I'm sorry, I think it's, okay, sorry. So, of the 68 who contacted the study for screening, 22 were assessed for eligibility, while 46 were excluded. And then of those who were assessed, 7 were allocated to group 1 and 3 were allocated to group 2. Of those who participated in the intervention, all but 1 completed both entry and exit questionnaires. So something really important to note here is that the high number of participants who reached out with interest but did not follow through to complete the screening. And then during the second exclusion stage, you can see that the majority were excluded due to high depression symptoms that warranted individual proven care. And we'll come back to that later. So now, once we've gotten to our participants, you can see the demographics of our pilot study in this table. And all the participants identified as female, median age was 18, majority people of color, under half were pregnant, half were bilingual, and the majority listed Medicaid as their source of insurance. For acceptability, we use the Acceptability of Intervention measure. The questions are listed below, and we recorded an average score of 4.28 out of 5, with 100% of participants noting that they would recommend the IMAGINE program to a friend. Utility was analyzed with regards to how often participants used key CBT skills, and if used, how helpful the participants would find it to use the skills. The 3 domains of skills were activities, thoughts, and contact with others. So we have data here for the skills that participants reported as being used half or more days in a week. And we can see that all the CBT skills were marked by 50% or more of participants, with the exception of worry time and made a request using assertive communication. And then when looking at helpfulness, we asked participants who reported learning the new CBT skill how helpful it was for them to use it. Participants found that the thought interruption technique and several skills from the contacts with others domain were most helpful, but we see worry time, time projection, and assertive communication ranked with lowest levels of helpfulness.
2 minutes.
Thank you. For Aim 2, we wanted to understand influence on mental wellness using pre-post tests. So depression scores appear to decrease, perceived stress is maintained, perception of family social support increases, and friend social support decreases. But very important to note that these numbers are not statistically significant due to the small sample size, and we can take them along with other data to help us inform future larger trials and better understanding ImagineMed. So in summary, for this small scale pilot study, we were able to observe high acceptability of the intervention, with 100% of participants noting that they would definitely recommend Imagine to a friend. Many of the core CBT skills within the contact with others, thoughts, and activity domains were utilized, with some key exceptions, such as the use of assertive communication. And in terms of uptake, we saw that there was high initial interest, but the steep drop off for those who made it to the screening. And a key recommended question that my thesis highlights is for future studies is that many interested and enthusiastic participants or recruits were referred to clinical care due to high depressive symptoms, and they couldn't participate. So that's clearly a population that needs to be better served. So in sum, this data gives us promise for Imagine's future impact on mental wellness, but further trials are definitely needed. And to end with limitations, our sample size, as we discussed, limited the statistical significance. A key limitation was also that the study was conducted during the height of COVID. So these circumstances heavily impacted our recruitment process and participant engagement. Though the program was virtual, the initial touch points to establish credibility and trust and understanding of the program were definitely compromised. And while COVID did hinder our process, it definitely highlighted the importance of the topic in establishing resources for mental health that can surmount different types of obstacles. Finally, as somebody who conducted many of the entry and exit interviews, just want to reiterate that my positionality should be considered as a limitation and relevant factor. So with that, I will say thank you primarily to the participants and the interested young parents who trusted us with their experiences. And then of course, everyone who is listed here. Happy to take questions.
Thanks, Anupa. I actually have a burning question, if you don't mind, I would like to ask, and then I see Bernardo's also has a question in the chat. So my question was, I was going to ask you if you thought that the participants may have had challenges in accessing the electronic, format. But after hearing about the number of people who, didn't make it in because they didn't complete the screening forms, I wonder, do you think that there was an interaction between depressive symptoms and electronic media that over and above just the difficulties in getting to mental health treatment, if there is some kind of additional barrier that is posed by accessing the electronic media?
Yeah, so I think for the participants who were able to be enrolled and made it through those enrollment interviews and screening processes, we were pretty intentional about the orientation process and walking participants through, like, this is how you use the platform, what's the, and the facilitator had a protocol for checking in with people who were not necessarily responsive or if they had tech issues. But I will say, like, to the point of people who showed interest and then didn't make it to the screening process, or maybe didn't make it to the enrollment interview, each of those processes, entailed at least an hour-long interview, potentially on the phone or on Zoom, requiring, we had a lot of interviews where people were struggling to find a quiet place to connect to the internet, to access the forms. We tried to use a technique of screen sharing some of the forms that were more complicated so that it would reduce the burden of having to, say a survey over the phone extensively. And I think that pointed out that it's an hour-long enrollment interview. It was no small feat to try and schedule for somebody who was already juggling a lot. And especially like you were mentioning, if there's an interaction of depressive symptoms and being able to like use a new video chat device with somebody that you've never met before and kind of complete that screening process, I think it's very important to consider that in the process as a barrier.
Thanks. Nora, do you want to read out the question?
Yeah, so I'm going to batch these two questions together. So one is from Bernardo, who said, if you had a chance to replicate this evaluation in the future, would it be possible and ethical to include a comparison group? Also, how? That's the first question. Second question from Farah, who says, was there any qualitative data gathered during the enrollment/exit stages?
Yes. So we were planning to recruit a control group. That was in our initial recruitment plan when we were a little bit more optimistic about how easy COVID era recruitment would be for a new study. And I definitely think that that's in the future plans for future Imagine study activities. And in terms of qualitative data, we gathered a lot of really, really rich qualitative data. And I felt really fortunate as I was doing this quantitative analysis to have that also in my mind and as part of my data collection experience, because it really completed the picture in an important way. We have qualitative data collected for the formative research, but then for specifically the exit interviews, I think another MPH student will be analyzing the qualitative data from the exit interviews as part of their thesis. So hopefully together, both of our analyses will provide like a really rich picture for what happened here and sharing the experiences of the participants.
Perfect. Thank you so much for those responses. So we're at time. However, there is a question from Delaney Glass in the chat box. So if you can please address that publicly, that would be great.
Sure. Thank you.
Anupa.
Great, thanks. Okay, so next we have Shady Henrichy. So you have the floor.
Thank you, Deepa. Can you see my screen, everyone? Can you see it?
Good. Yeah,
good, awesome,
great.
Perfect. So good morning, everyone in Washington, Seattle, and good evening to some people that are invited to this Zoom session on my in Africa. So thank you for being here today. I will be presenting my thesis research, a systematic analysis on the malaria situation in the Republic of Cote d'Ivoire. My thesis chair is Awa Kone, and my committee members are Steve Gloyd and Tsanga Moaz Tiu. So as I said, I will be talking about malaria in Cote d'Ivoire, and I will be starting by two background slides. Malaria is the first cause of mortality in Cote d'Ivoire, and this is happening from 2009 till 2019. It's still the first disease in Cote d'Ivoire that is killing people. 3% of global malaria cases are in Cote d'Ivoire, and 2% of malaria deaths are also in Cote d'Ivoire. Talking about the epidemiological situation in Cote d'Ivoire, the whole country is endemic, so everyone living in Cote d'Ivoire is at risk of getting malaria, but it's a bit different from district to another because of the distribution of the vector of malaria, and if it's like people living in a community, rural area, or a big city. So as you can see, there are three main distribution of malaria cases: 250 to 450 cases, 100 to 250 cases, and less than 100 cases per 1,000 inhabitants per year. Talking about malaria, so we started with asking questions, and we fixed two aims. The first one is investigating the most recent key indicators of malaria situation in Cote d'Ivoire. And the second aim is to examine and to understand the main sources of money and funding to control malaria in Cote d'Ivoire. And as well, how we're going to control the vector, malaria and pregnancy, the distribution of bed nets, and the case management and the treatment of malaria. For the data collection, we did a literature research. So we collected peer-reviewed journals, documents from the Ministry of Health in Cote d'Ivoire, documents from NGOs in Cote d'Ivoire, fact sheets, other relevant resources from ERA organization in Cote d'Ivoire. And I used databases like Google Scholar, PubMed, WHO Global Health Observatory, and the Web of Science. For the research theme, since I'm a Francophone, I speak French, is my second language, and I speak English. So I try to find literature in French and in English, because Cote d'Ivoire is also a Francophone country. So we use malaria or Polydes and the name of the country, Cote d'Ivoire or Ivory Coast. And I started from 2014 till 2021 because there was a huge efforts before 2014, but still the situation stagnating since 2014 till 2021, also considering some political instability before 2014 in Cote d'Ivoire. For the review process, I used the website Covidence, and we started with 268 studies important for screening. 85 were removed because there were duplicates, and we finished by 65 full text studies, and that we excluded also 13 after reading and assessing them for eligibility. And we used 37 records from gray literature, and in total, we assessed 89 total records for this study. Talking about results of my thesis, I divided them in themes. So the first theme is malaria vector control, and it's basically on distribution of long-lasting insecticidal nets. In Cote d'Ivoire, mainly there is mass distribution every 2 to 3 years. Also, long-lasting insecticidal are given to pregnant women during antenatal care, to kids during immunization programs, and community health workers can provide these long insecticidal nets for everyone who is asking for that. The IRS, or indoor residual spraying, still very a method that is not very well deployed in Cote d'Ivoire.
5 minutes.
Also, the second research theme is malaria case management. So malaria treatment is based on ACTs in Cote d'Ivoire, and the use of rapid diagnostic tests. 6.7 million of RDTs are used every year in Cote d'Ivoire, but still the Cote d'Ivoire needs to work more on microscopy diagnostic and train more healthcare workers to do the microscopy diagnostic. The third theme is malaria and pregnancy. Cote d'Ivoire adopted the 3 doses of intermittent preventive treatment for pregnancy. IPTP are directly administered during ANCs. This is the lowest malaria indicator in Cote d'Ivoire. Only 41% of pregnant women in 2020 get 3 doses of IPTP. And also high rates of antenatal care is not associated with high IPTP intake. For the behavioral change, there is UNICEF and other organizations who are focusing on behavioral change to tackle malaria in Cote d'Ivoire. We found that 80% of the population in Cote d'Ivoire are not aware of malaria. They are not aware also of that malaria is free of charge in Cote d'Ivoire. And community health workers, sometimes they charge parents for malaria treatment. And we still need to work on the communication and the distribution of IPTP in Cote d'Ivoire. Talking about the last theme, malaria funding in Cote d'Ivoire, there are 4 main funders of malaria control: the Global Fund, USAID, the Presidential Malaria Initiative, UNICEF, and the Ministry of Health and Public Hygiene in Cote d'Ivoire. The biggest gap here is like the grants of the Global Fund are usually, they allocate a lot of money for the country, but usually a low percentage is dispersed because of many reasons. The USAID is allocating 25 million US dollar every year. And the budget of the Ministry of Health in Cote d'Ivoire, it's 2.6% of the budget is allocated to fight malaria. For this study limitations, generalizability of findings, selection bias, also the time shortage to go through many articles and reviewing them, and limited publication and funding for malaria research in Cote d'Ivoire. They're comparing to other countries in Eastern and Western Africa. Discussion of this study, we figured out that since 2014 till 2017 and 2019, the situation of malaria is stagnating. It's not increasing, but there's still like between 3,000 and 4,000 deaths related to malaria in the country. And this can be related to the low coverage of IPTP. So we need more qualitative studies to assess this gap of IPTP, understand why this indicator is still very low, despite a lot of efforts from UNICEF, the Global Fund, and the government in Cote d'Ivoire. Also, we noticed that community health workers are charging parents money, so we need to do some studies and evaluate the work of community health workers, especially in rural areas. And other studies need to be done on the investment and the funds of malaria in Cote d'Ivoire, especially funds from the Global Fund, and why they are not fully dispersed. To conclude my study, despite the significant progress made to fight malaria in Cote d'Ivoire, it's not decreasing since 2014. We need to have more collaboration between international donors and local organizations. They need to be more involved. And funding can be made more available to small organizations, not only big organizations in Cote d'Ivoire. I would like to acknowledge my committee members, my family, the team of or the organization ERA in Cote d'Ivoire. They helped me a lot to access documents, and they provide me some confidential document from the Ministry of Health, document they are not published. Also, I would like to thank the Department of Global Health administrative team for their continued support. And thank you so much.
Okay, thank you, Shady. Nice work. You've got a question from Gift in the chat. I also have a question too. But,
So Gift says, how do you think COVID has affected the malaria situation in Cote d'Ivoire?
I think, the COVID happened in 2020, and I think it has affected a lot the malaria situation in Cote d'Ivoire. Especially, they predicted to distribute, they do the mass distribution of bed nets by December 2020, but they weren't able to continue this. So this may maybe include implementation of any necessary catch-up activities that are needed. to avoid any increase or any outbreaks of malaria cases, especially in rural areas. Mm-hmm.
Great. So I will read comment from Awa, who says, "Thank you, Shady, for this great presentation. It is very informative. To support your statement, together we will end malaria in Côte d'Ivoire, I invited public health leaders in the country to attend your presentation to appreciate your findings. You said that malaria should be a public health priority in Côte d'Ivoire, and you also said that international donors should provide more support. Are you placing the responsibility with international institutions more than the national government? If so, why?"
At some point, yes, because I was comparing the allocated funds for malaria research, and there was a big gap between Anglophone countries and Francophone countries, especially from big donors in the US. They were investing more. Maybe it's easier for them, but there is a huge difference between countries. Even they are all African countries, but there should be more equity in funding malaria research in Africa and African countries, despite the language they speak.
Great. And so we have a question from Bernardo, who says, "Very nice presentation. Do you know where the main bottlenecks in the fight? Do you know where are the main bottlenecks in the fight to malaria? Detection, treatment, vector control, all?"
Yeah, I think as I mentioned for funding, sometimes the grant is a huge amount of money allocated, but only the last grant from the Global Fund was like only 33% was dispersed. And maybe because these big donors are not involving local organizations. So the main bottleneck, I guess, these big donors and also the government, they should involve more people from the field and more local organizations.
Awesome.
Because they keep working on different indicators since now 2015, but there is no change. And there should be like more maybe qualitative studies. There's only like the majority of the studies were quantitative. We were quantifying always the number of pregnant women getting their IPTP, but we never had, and we never asked why this indicator, like doing some interviews with community health workers or gynecologists or who's providing the ANC, asking them why this indicator is still very low.
Okay. In 30 seconds, if you can answer this. I have a question about and this is from Barbara. I have a question about the coverage of the interventions. Is it uniformly distributed countrywide or based on the prevalence areas? Would this skew the results if we applied it nationally?
What indicators? Sorry, I didn't hear you very well.
Let's see. Barbara, are you able to clarify your question?
Yes, I can. Thank you, Shady, for your presentation. So my question is, like in the beginning of the presentation, you spoke about the difference in prevalence within Côte d'Ivoire. And then now we have all these malaria interventions, the IPTP, and the treatment for pregnant women. So is that, when you looked at your analysis, were you basing it on nationally, or were you also looking at maybe the different ways that it was applied to in the different areas? Maybe there's higher uptake within the high prevalence areas versus the low prevalence areas. Was that something that you considered?
Yes, I agree with that. And also it depends on if like that district has like a big city or not, because there is a huge difference between, I mean, in rural areas in Côte d'Ivoire, we have better like the indicators concerning IPTP are much better than in big cities. In big cities, they are avoiding getting medications for malaria. So it depends. If the district has like 2 big cities, the malaria cases will be very high. And if the district has like it's like a rural area, the malaria cases will drop.
Perfect, thank you. So we're at time, but you have two other questions, one from Deepa and one from Staley on the chat box. If you can please address that publicly, that would be great.
Of course, sure.
Thank you.
You. Thank you, everyone.
Thank you, Shadi, and thanks, Nora. So next we have Asad Naveed. So the floor is yours. Okay, I think you're muted and it's not me. So
oh, sorry.
You have to
Hi,
start
everyone.
over.
Good morning.
Good
I'm
morning.
Asad, and my presentation is on a Sierra Leone specific adult health intervention package for non-communicable diseases. Just a minute. Okay, some background here. So Sierra Leone has one of the highest mortality and morbidity rates in the world. And currently, the health service coverage index is 36% as of 2015. And household out-of-pocket expenditure is the largest source of current health expenditure in Sierra Leone, contributing to 64.6% in 2018. And DALYs and deaths attributed to NCDs in Sierra Leone in 2007 suggest that 33.9% of all DALYs and 39.5% of all deaths were accounted for by NCDs and injuries. And the GDP of Sierra Leone is one of the lowest in the world. It's 527.53 per capita. Okay, so as I mentioned here, 64.6% of health expenditure is out of pocket. So the other is actually from the government. So the government launched something called the Free Healthcare Initiative in 2010. And basically they provide free services for pregnant women and children under the age of 5. The government also provides free malaria testing to everybody. And Sierra Leone plans to start a national insurance scheme called SLESHI by 2025 to cover populations not already covered by the Free Healthcare Initiative. So identifying priority NCD interventions will help the Ministry of Health and Sanitation guide policies and action for implementation of SLESHI for NCDs. Why an NCD package for Sierra Leone? It can help to identify the highest priority NCD services and basically the best use of limited public resources. And it's an explicit statement of what services are guaranteed to be available and affordable. And the UN is pushing for universal healthcare worldwide. So this will also contribute to the UN SDG 3 agenda. So disease control priorities. So this work actually builds on the work by the disease control priorities, which is an ongoing effort to systematically assess the value for money of interventions for diseases worldwide in lower middle income countries worldwide. And the DCP third edition, launched about 2-3 years ago, presented a model list of health interventions that could provide good value for money in lower middle income countries. And it ranges from all areas, including infectious diseases to injuries to NCDs. So the DCP recommendations are meant to be a guide or a starting point for local priority setting and planning. So the objectives: to carry out comparative cost effectiveness analysis of NCD interventions from the recommended DCP interventions for Sierra Leone using local data. 2, to quantify the health impact, that is how many deaths and DALYs the new interventions will avert for the most cost-effective interventions for Sierra Leone and the additional costs the country could incur if these are implemented. Thirdly, to estimate the budget impact of implementing the most cost-effective NCD interventions within SLESHI. Next slide. Methodology. So basically, as I said earlier, the DCP has essential packages and they have 21 lists of essential health interventions. And these were identified based on the fact that they provide good value for money, they are feasible to implement in low and middle income countries, and they address significant burden of diseases. And they drawn systematic reviews, economic evaluations, and epi data. We obtained a list of the Ncd interventions only from the DCP3 and basically applied it to Sierra Leone and to do the cost effectiveness analysis. So these are the list of interventions here. And basically, they are interventions that could be implemented at various levels, like community health center, first level hospital, referral hospitals, and also intersectoral policies. So methodology. So basically, we used we got epidemiology data from the WHO GHE and also from COMSA. So COMSA is a local survey of mortality data done through verbal autopsies. So using that, we got age and sex specific mortality information. We got demographic information from the UN WPP, World Population Projections. And we got DALI ratios from GBD data. The costs, we used the costs that were calculated by DCP3, and basically these included tradable and non-tradable costs. And then we created a projection model where we calculate the baseline assumption where nothing is nothing is done, like things continue as they are now, an intervention scenario where these interventions are applied, and then we did comparative cost effectiveness analysis. Next slide. So this slide just tells you a bit about the methodology. So every year so first of all, the population continues to change every year, and that depends on births, deaths, and migration. And using that, we know the mortality rates of diseases. So these are the baseline mortality rates increasing for NCDs. These are not to scale in white. And the green ones are the lesser mortality rates if interventions addressing NCDs are implemented. Down here, the white ones are baseline costs, and the red ones are costs if these interventions are implemented. As you can see, the costs go up. Next slide. So the first analysis plan was to do interventions independently. And in step 2, we were to combine all these interventions based on step 1 that are the most cost effective and see what will be the combined effect on the country, how much deaths they will reduce and how much will be the costs. So preliminary results. So so basically we calculated ICERs for the interventions on baseline coverage scenario versus a scale up at 5% and calculated ICERs. And basically these values you see here is the ICER per GDP per capita. So basically why we were doing that is the GDP per capita is usually the threshold level at which governments can spend for health interventions. So if the ratio is 1, it's ideal. Up to 3 is acceptable. Going up is above the country's threshold to pay for interventions. So basically, and on the right-hand side, these are intersectoral policies, and they cost nothing, so they will be included in the package. And basically, these 3 clinical interventions you see on the left here are the most cost-effective for Sierra Leone. These are preliminary. We have just done a preliminary analysis on R. So in terms of deaths, so if nothing is done, this is how the deaths will continue to increase due to NCDs. But then if all interventions are implemented, the deaths will drop significantly. And if only 5 are done, it will drop. But then there's this middle level. If the top 5 cost-effective interventions are done, you will be in this situation. This big drop is due to actually intersectoral policies. And basically, the magnitude of the mortality depends on the number of interventions in the package and the coverage level. So as you see, that still continue to increase because the population is aging and NCDs continue to rise overall, but these could help.
2 minutes.
Yeah, I'm just rounding up. So these are preliminary costs. So the costs, this is an intervention scenario and this is baseline. And basically in 2030, the cost, if these NCD interventions are done, they will make 10% of the total budget in 2030. Currently, the budget is 66 million for health based on, so discussion. So Sierra Leone has limited resources and will need to ration Ncd intervention based on the most effective ones. And basically this analysis helps to tell the government which ones are good for the slushy package. Substantial changes in Ncd mortality could be achieved by intersectoral policies on smoking and alcohol use, for example, tobacco taxations. And this Ncd sub-package cost will likely be a reasonable but not unmanageable share of the total health budget. So the limitations are that we currently use global estimates for mortality rates and also costs. And the COVID has also impacted the feasibility of interventions. So we're not clear whether 5% increase can be sustained right now. Regardless, this is a step forward. Future work, so we'll finalize the projection model and do a budget impact analysis, and we'll replace the EPI data with COMSA data, which is a local data, and also replace costs with local costs. And we'll write up final results as a peer-reviewed manuscript as part of the Queen Elizabeth Scholar Program. And this will help in creating a policy brief for the Ministry of Health in designing SLESHI. So special gratitude to Sarah, which is a former MPH student, and Dr. David Watkins and Dr. Monisha Sharma. Thank you.
Thank you, Asad. Nice job. I see you have a question from Steve in the chat.
Yep. So Steve says, very nice presentation. Is it realistic to treat a patient for CVD but not treat diabetes in the same health system?
So ideally, the best scenario will be to treat them for any condition they have. But what this analysis does is it looks at the most effective interventions so that they for the resources available, and proposes that they are scaled up to reduce mortality and DALYs in the country. So if the country's spending threshold or the cost effectiveness threshold increases above the GDP per capita, or using through other resources such as grants, these interventions could be scaled up further and more interventions could be included. And hence, that would be an ideal situation where a government could either fund more interventions and scale up to cover more areas. It could be from self-generated funds too, which is ideal actually.
Great, and there's a comment from David Watkins to Steve, who says, the idea here is that these interventions are the ones that are publicly financed. Diabetes care is still available, but must be paid for out of pocket because there are not enough government resources.
Yeah, I have a quick question because I don't see any other questions. Do we have time, Nora, for me to ask it?
Yes, we do.
Okay. Asad, I'm wondering if you include policy interventions in the intervention package, or if the interventions are just limited to, healthcare worker delivered interventions.
Yes, policy interventions are included, and actually they make a big impact on the mortality rates. These include tobacco taxations, alcohol regulation, salt regulations, and basically they impact mortality rates and also in fact generate revenue for the country, and whilst reducing diseases. So they are included in the package because they cost almost nothing to implement.
Okay.
Any more questions for Asad? Well, it was just so good that no one asked questions.
Very complex. So nice to hear about this body of work that it sounds like is still ongoing. So meaning you'll be putting together a paper for submission. So great work.
Yeah,
great.
Well, if anything comes up, please feel free to add your question in the chat box for Asad to get to. I think with that, Deepa, we're ready to go to our next presenter.
Yeah, next we have Shoita Sanopuri. So you have the floor.
Let me just. I'm not able to share my screen.
Oh, sorry. Give me 1 second. There you go.
All right. Give me a second. Okay, can everyone see this?
No, not yet.
Okay, I am sorry for the issues it's making.
There you go.
I am unsure of what screen is sharing.
Okay, it's sharing. There it is. Perfect. Right now we're good.
Okay, I'm not sure if you're seeing the presentation mode or like the notes.
We're seeing the appropriate mode that we need to see. So we're not seeing any of your notes.
Okay, cool. Great. All right. So good morning, everyone. My name is Shoita. I am an MPH candidate in the Global Health Metrics Evaluation Program, and I go by the pronoun she, her. So over the past few months, I worked with Dr. Prado and Dr. Hockenstad in evaluating the intervention aimed to increase recognition of alarm signs in children under 5 in Yucatan, Mexico. And today I am here to present my thesis project. So in this presentation today, I will be starting with a brief background discussing the motivations for my thesis project and what brought me to my aims and objectives. And then I will briefly go over my methods and data analysis process before presenting my findings. And finally, I will end with a discussion on the implications of the findings and limitations. Before I continue, I want to acknowledge my positionality in this thesis work. I conducted research on secondary data, which was translated from Spanish, which is a language I am not too familiar with, and also want to acknowledge that I am not from the community that I looked at the data from, considering my background as a South Asian woman with Western education. I am constantly learning to be respectful and mindful of all of this and with the community I work with for following researches. To continue, improving child health and reducing child mortality is a universal objective. Access and quality of care are two critical elements in reduction of child deaths. And Mexico has successfully improved its under 5 child mortality rate from 62% from 41.2 deaths per 100 live births in 1990 to 15.7 deaths per live births in 2017. However, the mortality rate in Mexico for children under 5 is still double the rate as it is in the United States, indicating a room for improvement. A collaborative study by the Institute of Health Metrics and Evaluation and the University of Yucatan developed a project to understand the bottlenecks in the search for care in communities in the state of Yucatan. The team conducted verbal autopsy interviews with caregivers to identify challenges they faced in obtaining critical care. And upon analysis, they found that the most significant delays appear to arise from caretakers' decisions to seek medical care. To seek timely care in a health facility, caregivers need to identify the warning signs and symptoms of common diseases that could affect children under 5, and failure to do so can have fatal outcomes. Following the results of that project, IHME and UADY collaboratively developed community intervention in low-income and indigenous communities of Yucatan to increase awareness and knowledge surrounding recognizing alarm signs in children under 5. Initial analysis showed that the intervention effect to be positive but not significant. And this is where my thesis project comes in, to build upon the initial analysis and analyze the effect of this intervention among different subgroups of the population. I'm focusing on education and household size. So over here on the slide are the intended outcomes and aims of this study, which is to evaluate whether community intervention has this differential impact within various subgroups in low-income communities, and also to investigate which subgroups had the most considerable difference in the number of alarm signs recognized between baseline and line values. This intervention took place in 8 rural municipalities of Yucatan, where 50 caregivers were recruited from each of the municipalities. Randomization into the intervention or comparison group occurred at the community level, and the intervention took place for 6 months. Initially, the intervention included workshops about healthcare risks during childhood and strategies for care search. However, due to the COVID-19 pandemic, the intervention team had to modify their ways to adhere to public health safety rules. Participants filled out questionnaires which evaluated alarm sign knowledge for the following health conditions: general medical attention, sepsis, respiratory infections, and congenital heart defects. Baseline data was collected in person between January and March 2020 on an electronic survey software called Survey CTO, and follow-up data was collected using paper surveys between September and November 2020 with condensed questionnaires. As the intervention was randomized, the data collected was analyzed as a pre-test, post-test study, and additionally analyzed with a difference in difference study design. Right, so the number of alarm signs recognized under each of the 4 categories, general sepsis, pneumonia or respiratory infection, and congenital heart defect, and the total was collected pre and post intervention in both the groups. And we compared the average number of alarm signs I identified post intervention in the intervention group to the comparison group. Sorry, I have a cough, so I'm going to be doing that just a bit. We conducted OLS regression analyses on the follow-up data to look at associations and relationships between the increase in alarm signs recognized and the various subgroups, such as stratified by education and household size. Equation 1 over here is the crude regression model we used to identify the changes, and we stratified this for education and household. We also conducted an adjusted equation adjusted for household size and education. Participants who had an education of primary school or less were classified to have low education and coded as 0, and those with secondary education or higher were classified as high education. And similarly, for participants who had a household size less than 6, were classified into the low household size group. In order to account for the non-observable factors that could have interfered with the impact of the intervention, we also conducted a difference in difference analysis. For a little bit of background, the difference in difference technique is a quasi-experimental design that uses longitudinal data from treatment and control groups to obtain information to estimate the causal effect. This analysis estimates the impact of specific interventions by comparing the outcomes over time between the intervention and control group. Okay. So just to check if the randomization of the communities was effective in generating comparable groups, we conducted t-tests between the control and interventional group. And table 1 over here outlines the demographic characteristics of the caregivers that provided complete information at baseline and at follow-up. Education was the only variable in which there were significant differences between the intervention and comparison groups. For the following slides, I will display the DID analysis results to respect the time and discuss the implications of that.
2 minutes.
In this slide, I've visually displayed the categories where we found significant intervention effect. The DID model stratified by education shows us caregivers with low education increased their knowledge of heart defect alarm signs by nearly 1 additional alarm sign. However, caregivers with high education did not experience a statistically significant intervention effect in the same alarm sign category of heart defects. Similarly, the DID model stratified by household size showed us that caregivers living in high household sizes increased their knowledge of alarm signs, but this effect was not visible in caregivers who lived in low household sizes. And when looking at the change in alarm sign recognition over time, we observed an increase in alarm sign knowledge in both of the intervention and comparison groups across all 4 of the categories, as I've displayed on this slide. And from the DID analysis and the OLS regression analysis, it was evident that the intervention, though not having an effect on the overall population, had a positive effect in the increase in hard defect alarm signs recognized and the general alarm signs recognized in caregivers with low education and caregivers in high household sizes. As mentioned just before, I did observe an increase in alarm sign recognition in both the groups, and this is possibly due to the fact that the intervention was carried out during the pandemic. A discussion with local stakeholders confirmed that with the onset of the pandemic, communities had been approached by various health promotion programs, leading to an overall increase in alarm sign recognition during the duration of the study. Quickly moving on to the limitations, one of the main limitations of this project was the impact of the pandemic on data collection. Information materials replaced workshops to be mindful of the restrictions, and due to this, there was no way to monitor whether caregivers reviewed the intervention materials. And this may have reduced the effect of the intervention and therefore presents the evaluation as a conservative assessment. Another limitation was in the difference in data collection. Baseline surveys were collected in person electronically, and whereas the follow-up was collected using paper surveys with condensed questionnaires. Due to the limited space on paper, some questions were edited and removed. However, no change was made on the wording and formatting of caregiver knowledge of alarm signs. It is also possible that the intervention information transferred to the comparison municipalities through social and economic interactions caused by the proximities of the communities, providing more insight into the overall increase in alarm sign recognition. So quickly to conclude, finally, this study shows a positive increase in alarm sign identification post-intervention and a significant intervention effect in caregivers with lower education and living in larger household sizes. And this highlights the need for further interventions to improve access to care in reducing child mortality in low and middle income settings. And this intervention can be set as an example for implementing similar programs in neighboring communities in Mexico, and the data from this study and future studies on this intervention can provide strong evidence to develop future health policies and interventions in Yucatan and other Mexican states. Thank you. I would like to quickly thank my thesis committee for their support and guidance, Dr. Prado and Dr. Hockenstein. I would also like to thank Ms. Louisa Johnson for her guidance through my data analysis, and my family and friends for being my support system. Thank you.
Thank you, Shoita. Nice work. Just going to pause and see if there are any questions from the audience before I ask one myself. Okay, I paused because I hope that this question isn't a challenging one, but I really appreciated hearing your thoughtful positionality statement at the start of the presentation. And I'm wondering if you could reflect upon how your positionality may have positively or negatively impacted the design and interpretation of the results. Or interpretation of results, I should say.
So I'm gonna have to think about that for a moment, but I was not involved in the design of the intervention. I only conducted data on the data that's already been collected, but I would think that coming from growing up also in a quite populated country like India, I was able to kind of reflect my what I observed through my experiences over there about the impact of education and household size, which was one of my personal motivations to choose those subgroups. I do definitely think there are various other subgroups that might have had an impact, but due to the shortage of time I had to work on this project, I chose these. But that's kind of where I believe my experiences in positionality did it, like, I don't know if interfere is the right word, but did motivate where I took this project for myself.
Yeah, thank you. Thank you for such a nice answer.
Thank you.
Other questions? I'm not sure. Noor, are you seeing anything in the chat?
I'm not seeing anything right now. Okay, looks like we've got a question from Bernardo, who says, nice work. Do you think the impact found on less educated or women living in high-size households should lead to specific interventions of these groups?
I definitely do believe that it is important to be mindful of this, especially when developing intervention materials, for that to be readable and understandable to caregivers who have less education. And also to, when you're developing materials or policies, high household sizes also might have an effect because of more sharing of resources and trying to think of like suggestions that are mindful of this. So I do believe that this would be helpful to make more targeted interventions in the future, especially in low and middle income countries where this is more.
Wonderful. Thank you so much for your presentation. It was absolutely amazing. Thank you.
Thank you.
Yep.
Okay, so I guess we'll move on. And if anybody else has any other questions, please do put them in the chat. And Shoita can answer in the chat. So next we have Linda Oluch. So Linda, you have the floor. Everything okay?
Yes, just give me a minute. Sorry about that. I hope you can see my screen now.
Yes.
So
We
thank
can
you.
see it, and we're looking at the appropriate screen, so it's all good.
Okay. So my name is Linda Oluoch, and I'm MPH Global Health General Track student. I'll be presenting on vaginal dysbiosis among Kenyan adolescent girls and young women at risk of HIV before and during first pregnancy. My thesis committee members are Alison Roxby, Dr. Nedi Mugo, and Dr. Kenneth Ngure. So a bit about my personality. I'm part of the community from which I did the study from. I'm Kenyan, I speak both languages fluently. And I'm a clinician, so I have some bit of clinical practice experience and some bit of research experience. Most of my work focuses on reproductive health in adolescent women and adolescent girls and young women. And I work for the Kenya Medical Research Institute. So I'll explain a few terminologies I'm going to use in my thesis presentation. GHS stands for Girls Health Study, which is a parent study under which my thesis study was nested. AGYW refers to adolescent girls and young women who form the cohort under my study. BV is infection, bacterial vaginosis, and the Nugent scoring is a scoring system that is widely used to diagnose BV infection, and a score of 7 and above is considered positive for BV diagnosis. A bit of background and rationale as to why I'm doing this study. We have very scarce data on longitudinal changes in BV status of young women between sexual debut and incident pregnancy. And just particularly worrisome because this particular cohort is quite vulnerable. We have early sexual initiation that is common in this cohort and is associated with a very high risk of BV, pregnancy, HIV, and STI simultaneously. So you know that BV is known to increase risk for adverse pregnancy outcomes like preterm births, miscarriages, low birth weight. And we really don't have a lot of information on what effects pregnancy has on BV on young women. And a lot of the data that you have that is prevalent is mostly on older women in terms of how BV affects women reproductive health age. And we are hoping to close this gap by collecting new data on these young women and also pulling them up longitudinally. So my main aims for the study are those two. I want to determine the longitudinal changes to BV trends prior to and during pregnancy in this cohort of young women. Also want to look at the correlates of increased incident pregnancy in a cohort of young women. So this study of mine was nested in a parent study, and I did some data collection. And this particular study was a prospective study that was designed to determine whether or not acquiring herpes simplex virus 2 infection in young African women led to persistent genital inflammation, which puts them at a high risk of HIV. So for my thesis, I only focused on the swabs we took for BV diagnosis, and we used the scoring system to assess whether or not they had BV in this cohort. So the study was done in Thika, Kenya, which is like 40 kilometers from Nairobi, the capital city of Kenya, and the clinic site was Partners in Health Research and Development, which is part of Cambridge and Kenya. And for you to be enrolled into this study, in the parent study, you had to be that age, 20 years of age. You had to have no prior sexual experience or just report one sexual partner. And you had to be HIV and herpes 2 negative, and you had to be willing to come to the clinic every 3 months for us to assess you and collect samples. So we did quarterly follow-up for this cohort of 400 young women. When they came in every 3 months, we did blood draws for HIV and herpes assays. We did genital swab collection for STI screening and also BV screening. We're able to collect some data on the reproductive health history in terms of when they last saw their periods and if they're actually using any contraception as they're having sex. And for pregnancy testing, it was only done on request, or if the girl had actually reported that actually missed their period the last visit, and we had to confirm whether or not they were pregnant. So I used the different methods to describe this cohort, and we used regression analysis to analyze longitudinal trends in BV prior and during pregnancy. We tested for covariates of BV infection and looked at Cox regression to look at the correlates of increased risk of incident pregnancy. So for the study cohort, in terms of all the 400 girls who were enrolled, the median age of enrollment was at 18.6 years. 80% of the girls had no prior sexual experience when they came in. The age at MENAC, which is the time when you first see your periods for a young woman, was a median age of 14 years. And the time between MENAC and sexual initiation was at 4.9 years.
5 minutes.
So we enrolled 400 girls into this cohort, and only 306 girls reported having had sex by the end of the study follow-up, which was for 16 months. Some of pregnancies that actually were confirmed in terms of first pregnancies in this cohort was 127. Unfortunately, we actually had like 3 missing values, so we could only analyze 124 pregnancies in this particular study. So we're able to screen 119 girls just before they got pregnant. And out of this, 45 had a positive of BV, and also able to screen 105 girls during pregnancy in the same cohort. And out of them, 24 girls had BV. So what you're looking at is a spaghetti plot. I'm trying to just show you the region scoring system. I had mentioned before that if you had a scoring of 7 and above, that was considered positive for BV. And we saw that pre-pregnancy, we had higher scores, region scoring system for BV, higher positive BV diagnosis compared to after pregnancy. And we didn't find any strong evidence that prior BV infection just before pregnancy was associated with the higher risk of BV infection during pregnancy. So we adjusted for covariates, look at the risk of BV during pregnancy, and we found there's a higher risk in girls who had a history of recent STIs, that was chlamydia, trachomatis, and herpes infection, and also for girls who had a shorter time between menarche and sexual debut, that is less than 3 years, were at a higher risk of getting BV during the pregnancy. For pregnancy itself, the first incident pregnancy in this cohort, there's a higher risk if you had sex in the past 90 days, or you did not use any condoms, or you had a short time between menarche and time of sexual debut. For some reason, living in urban areas conferred a lower risk incident for pregnancy, and also having a new sex partner. And I'd like to note here that most of the girls who reported pregnancy in this cohort, 30% of them actually reported to have been married at that time and were in stable relationships. So for my key findings, BV rates were higher in pre-pregnancy, and the pregnancy incidence in this cohort was a bit high, which was worrisome because they used to come in quarterly for counseling and contraceptive uptake. And compared national prevalence, it was 32%. We had very low sexual activity during pregnancy, and sexual risk factors as STIs increased risk of BV infection. So we had a few limitations in the study. Sample size was a bit small, and the findings may not reflect the larger populace. And the specimens were done every 3 months during pregnancy, so we didn't have intensive sampling, and a few of the girls were not comfortable having samples collected during the pregnancy state. Douching is a high risk factor for BV, but unfortunately it was added quite late in the study during amendment, and hence we had inadequate data to collect, and we couldn't analyze it. And we had incomplete data on pregnancy outcomes, and hence not included in the results section. So pregnancy did not increase rates of BV infection, even though we know that in pregnancy we have a prevalence of BV which is high in other older cohorts. And we were able to collect data longitudinally in this particular cohort, which we hope will add on to data that's already there for older women. And we like to do more studies, look at the biological factors that actually determine the dysbiosis from the period of sexual debut to the early pregnancy in this cohort of young women. So I'd like to thank my thesis committee, Dr. Alison, Dr. Nelly, Dr. Kenneth, for all their support, and for the Cambridge and UW study team. I'm very grateful for the study participants actually came in every 3 months for us to collect this data, support from IRTP and the funders for the main study. Thank you.
Thank you, Linda. Nice work.
Thank you.
Any questions from any audience members? I don't see anything in the chat yet.
Looks like Renee has her hand up. Renee, if you'd like to ask your question.
Can I ask directly? Thanks for your great presentation, Linda. I'm just curious, you have such a high incidence of pregnancy. Did you ask any questions, either qualitatively or through surveys about fertility desires, and how might that have been going on in the cohort?
Yeah, so we have a study going on in terms of contraceptive uptake in this cohort, but to answer your first question, we actually asked the girls if the pregnancy was intended, and 30% actually said yes, because they were married and they were hoping to get their kids as early as possible. Most of this cohort had done 12 years of education, and for them, they could not progress any higher, and they had dropped out and could not go to college. So it was part of their social conditioning, at that age, it's the right age to have kids and to move on in their lives. So yes, we did ask them if it was intended or not, and 30% said yes.
Thank you.
Looks like there's a question from Steve, who says, great presentation, Linda. Did you measure the levels of douching pre and during pregnancy, given that it seems to be a big risk factor for BV?
Yes, thank you, Steve. We actually did measure the douching pre and during pregnancy, but as I mentioned earlier, we didn't start from the beginning of the study. It was done much later, and when you adjusted for the relative risk of BV with douching, we saw there was a high risk of 1.74, but it was not statistically significant. It was actually less than 0. It was more than 0.05, the p-value. so we could not add it in the results. Which was a bit skewed because we didn't have like enough data for us to make a conclusive statement in terms of whether or not douching in this particular cohort was a risk factor.
I kind of, my question is a follow-up to that, and see, I don't see any other questions in the chat, so I might ask it if it's okay. You know, in the United States, there are subpopulations where douching is acceptable and others where it's not acceptable. What is it like in Kenya? And I ask because, you know, if you do ask participants, they may or may not respond to your question about whether they're douching if there's stigma associated with it, right? Social desirability bias. So that's why I asked the question.
Okay, so that's interesting because when you asked the girls if they're douching, we had to explain what douching was for them to give us the answer that we're actually asking for. Most of them thought it was actually quite normal to wash a vagina with soap and water, and we had to have like a whole session in our counseling just to tell them, please stop. It's actually self-cleansing and actually you're harming yourself. So we tried to like gauge in terms of what douching persons were doing and who told them to douch. And we have like a whole qualitative research team doing that study right now. And I hope to share the findings when I get them. But yes, it's a common thing in Kenya. Most people douch, they have no idea it's harmful. And they're trying to reverse this through health education with these young women.
Okay, thank you, Linda.
So I'm going to batch these two questions together. One is from Steve, who says, what is the difference between vaginal, oh my gosh, dysbiosis? Steve, you're putting me on the spot. And then bacterial vaginosis. And then the question from Barbara says, my question, is it possible that young women stopped sexual activity because they were not really in a marital relationship, that they culturally report marriage to explain the pregnancy, which is stigmatizing at that age?
Okay, so I'll start with Steve's question. So when you talk about dysbiosis, we talk of an overgrowth of anaerobic bacteria in the genital tract. And bacterial vaginosis is one of the conditions that come out of the dysbiosis. So when you mess up with the microbiome, the vagina, then one of the conditions you actually get is bacterial vaginosis. And then to answer Barbara's question, that could be true. We didn't really ask them why they stopped having sex. We just actually did like a quantitative like collection just to ask them like in the past 3 months, how many times have you had sex? So we didn't really like connect the two, but that could be actually true. Yes.
And how are we doing on time, Nora?
30 seconds.
Okay, time for another quick question. Which I don't see any takers, so I guess we'll move on if that's okay. Okay, and thank you, Linda, so much. And if anybody has any other questions for Linda, please put them in the chat and she can answer. And next we have, and last but of course not least, Nicholas Boratool. So you go ahead and take the floor.
Thank you. Kindly provide sharing rights. I don't seem to be able to share.
Sure, I'll try it again. There you go. Is everything all right?
Sorry, it seems to have hung. Could you share for me, please?
You want me to share your presentation?
Oh, we can see it now. We can see it now. It just took a second. Nicholas? We can see it. The one thing is we're seeing the small slides. So if you can put it in presentation mode. And now we're seeing your notes. So is there a way to swap screens as Katie taught? Oh, there we go. Look, they're
Perfect.
seeing it. Perfect.
Thank you. Sorry about that. So thank you for this opportunity to present our research findings for you today. My name is Nicholas Duo. I'm in the MPH class, Global Health for 2021. My thesis committee includes Professor Renee Heffron, Professor Nelly Mugo, and Professor Kenneth Ngure. My presentation today is on sexual behavior and HIV risk among young women using PrEP in Kenya, and this is a secondary analysis. On my positionality, I am Kenyan. I participated in this study as a qualitative researcher. I am male, and I do speak the local languages. I am also a HIV counselor and a member of the community from which we recruited the young women. These are some of the terminologies that we'll be using. We're talking about adolescent girls and young women. Usually this refers to the age group between 15 and 24. But for purposes of this study, I'll be looking at those aged 18 to 24. MPIA was monitoring PrEP amongst young adult women. This was the main study. It also means new in Swahili. The voice risk score is a validated HIV risk measurement tool that has been used in different studies. And PrEP is an antiretroviral-based HIV pre-exposure pill. And we used TDF-FTC, otherwise known as Truvada, in the main study. So a brief background. So we know that adolescent girls and young women are more likely to acquire HIV than male peers. And they make up 2/3 of all new infections amongst the youth in sub-Saharan Africa. PrEP is actually been known to be very effective for preventing HIV, but persistence and adherence has been seen to be a challenge, especially in this particular population. The voice risk score was developed to be able to capture people who are determined to be at higher risk of HIV, and has actually been used in various cohorts and research studies. A gap exists in understanding sexual risk behavior changes based on this particular risk score over time. Our clinical trial sites were in Kenya, in Kisumu and Thika. Kisumu, Kenya is both urban and has also an urban, peri-urban and rural population, the same as Thika, which is also an industrial town. Kisumu has a HIV prevalence rate of 16%, and Thika has a prevalence rate of 4%, according to the National AIDS Control Council report of 2018. So our aims for this study, we look to describe sexual risk behavior amongst AGYW aged 18 to 24 over the 24 months of follow-up, which was done quarterly. I would include looking at the number of partners, condomless sex, and other correlates of behavior, and compare them with their scoring on the voice risk score for HIV. For our aim2, would describe the longitudinal perceptions of HIV risk, which were measured at annual intervals, that was at enrollment, month 12 and month 24, and correlate this with the risk score. For this presentation, I'll be focusing on aim1. For our methodology, we used data from the MPIA study, which enrolled 348 young adult women who were evenly split between the Kisumu and Thika sites. The MPIA study enrolled these young women aged 18 to 24 who were willing and able to provide informed consent, HIV infected as per national guidelines, with a HIV risk score of 4 or greater, who were willing to use PrEP for at least 6 months and owned a cell phone, as there was SMS communication to be done with the facility. Longitudinal data was collected. This was on condom use, the number of partners, the types of partnerships, the frequency of sexual exposure, and self-reported risk, HIV risk score, education, and age. So for our data analysis, We use descriptive methods to summarize sexual risk behavior over the 24-month period. We used logistic regression methods with GEE to estimate the association between the sexual behavior and the HIV risk score. For the risk score, we dichotomized it into low and high. Those who scored 4 and 5 were considered to be low, and those who scored 6 to 8 were considered to be high. And we used an R statistical package for analysis.
5 minutes.
So for our results, we did find that for our group had an average age of 21 years old. They were mostly had stable partnerships. There were over 30% reported earning an income, whether stable or unstable. They had over 12 years of education. In this case, this is completed high school. 4 women acquired HIV in the study, and 68% believed PrEP made sex completely safe. In this figure, we see the reported condom-less sex, which appears to rise slightly from enrollment. However, this could have been due to a reporting bias as they got comfortable with the staff. But of note is that it remained stable throughout the 24 months. And this was based both for casual and for main partners. On the association between the sexual risks, sexual behavior and the risk score, we found that those who scored higher earlier had reported having more than 2 partners, 27%, and those who scored lower had 0 to 1 partners. But on catering for confounders, we found that there was no statistical difference with an adjusted OR of 1.2. The frequency of risk score for condomless sex, we found that 35% reported condomless sex, while with a high risk score, and 31% with a lower risk score, and those who had a higher risk score were more likely to report condomless sex even when adjusted. And for those in terms of reporting casual partnerships, we found that there was a higher likelihood of those who had a higher risk score reporting casual partnerships than those with a lower risk score. But this was not significant upon adjustment. We adjusted for living arrangements, whether they live with their parents, their marital status, their work status, their age, and their marriage. And thank you. So for our key findings, there was no significant difference in sexual behavior between those who scored high on the voice risk score and those who scored lower. Overall, condomless sex after enrollment remained stable over the 2 years. Condom use by partner type was the same within the 2 years of follow-up, and this is significant because when you have main and casual partners and the use of condoms is not disaggregated between the two, has implications on HIV prevention. And the 4 seroconversions that were witnessed in the study were low based on the risk assessment score. The voice report showed that the expected seroconversions would have been greater than 3% per year. So the limitations, self-reports on sexual behavior may be influenced by social desirability bias, and we do not collect data on partner ages, which would have added another dimension to the risk profile of partners. No participants included in the study scored less than 4 at enrollment, meaning the general cohort was moderate to high risk to begin with. So in conclusion, with sexual risk behavior actually appearing constant throughout the study, and with declining PrEP adherence that was found within the main studies, additional prevention options for AGIW beyond PrEP may need to be considered. We also need to identify risk scoring tools that can be able to capture the differences between those who we may be considering at higher risk than others, and also understand that the measure of risk is actually quite complex, and we need to determine it in a context-specific setting. AGYW are actually a very dynamic group where environment changes are rapid, from school to work to home to marriages. And we also need to consider other risk factors and capture them appropriately when we are doing the analysis. I'd like to acknowledge my thesis committee, Professor Renee Heron, Professor Mugo, and Professor Ngure, the investigative team that did the MPH study, the MPH staff, and also IRTP that has supported me through this MPH program. These are my references, and I welcome any questions. Thank you.
Thank you, Nicholas. I think Nora got kicked off on accident, so I will open the floor to questions. It looks like we have one question from Steve already.
Yes.
Nora, are you back, or would you like me to read it off?
I'm back, but you can read it until I get settled.
Okay, all right. So great presentation, Nick. What thoughts do you have regarding why there was such low HIV acquisition among your sample, especially with such high percentage of condomless sexual activity?
Thank you. So there are two aspects that we are considering. One is something called prevention effective adherence. So the young women may have been using PrEPs at times that they considered that they were at high risk, and that would have resulted in prevention effective adherence. And secondly, just considering the reports about, we did not capture so much about their partners. And so if they changed their partners and had lower risk partners at any point in time, then they would still be reporting lower condom use, but less exposure to HIV. Thank you.
Great, thanks. Next question is something I'd like to add on to, if that's okay. Renee asks, well, says, nice job, Nicholas. Would you recommend that other studies use risk score in assessing HIV risk in their participants? And my kind of follow-up question to that I was pondering was, maybe you could talk a little bit about the pros and cons of qualitatively assessing versus quantitatively assessing risk score. Maybe that's just a bit more depth than Renee had posed in her question, but.
Yes, so the risk score had been tested in Southern Africa, where there may be differences, socio-cultural differences with the cohort that we found in Kenya or Eastern Africa. And so I think it may need to be expanded to include other issues. In terms of whether to qualitatively or quantitatively assess, this brings into light the role that is played by counselors when they're doing a risk assessment. And so what you can have is actually a combination. You can have the risk scoring tool and then have somebody who is qualified to discuss issues of HIV prevention, to then add on to the assessment and then have a combined response that would be able to give you a good response analysis of risk.
Okay, thank you. Nora, shall I ask the next question?
I can take the next question.
Okay.
So this is from Moira, who says, oh, actually, no, there's one from Barbara. Sorry, I missed that. So good work. My question is, why are we promoting both condoms and PrEP in this group? Condoms covers both HIV and STI. Why not promote one thing and make it simpler?
So in line with providing a comprehensive prevention package, we do know from past experiences and research that condom use has been a challenge, and especially because majority of the time it is controlled by the male partner. So PrEP provides an opportunity for the individual to make those choices. However, we have also seen low adherence within the group. So when you have a combined prevention package where both you have the multiple options, you're able to increase your possibility of having HIV prevention.
Great. And the final question is from Moira, who says, I know that your overall condom use was stable for the most part, but I could not help but notice the dip around 9 months. Is there any thoughts on this? Second, is this study, I presume, In this study, I presume because of the nature, they had more power on condom use negotiation. Do you think we can see such stability in a non-study setting?
So for the first part, maybe anecdotally, we may consider looking at any other interactions that may have occurred in the clinic. We do know after 6 months, we had weekly SMSs sent out discussing sexual risk behavior so that we could get real-time information. But we have not done any analysis to see whether that would have had any impact on the behavior. Comparing it with general population and people who are not getting regular PrEP services, this is something that would be interesting to look at, just to find out maybe from a public health setting in a public hospital and see whether the reports would are stable throughout. However, condom use has been reported to be a challenge in general across AGYW and other populations. Thank you.
Great job, Nicholas. Thank you so much for rounding us off and launching us into completion of the summer thesis presentations. So a couple of parting words. First of all, nice work, all of the thesis presenters. We really enjoyed hearing your presentations today. And also special thanks to the parents, the peers in your cohort, and the faculty and staff that helped to enable these projects. Really, we couldn't do what we do without you. So many thanks for all of your support and guidance and time and effort. And then special thanks to Noura Yusufa for organizing these presentations and, you know, sending the guidelines and tips to our presenters and helping to moderate the session today. Thanks so much, Noura. And I guess with that, we'll close. Thanks everybody for attending, and we'll see you next time, I hope. Stay in touch. Thank you.
Bye-bye.
Bye, everybody.